I'm going to call to order the second meeting of the House Early Childhood Finance and Policy Division. We're going to start with the clerk taking the roll.
Representative Pinto, Chair.
Present.
Representative Katiza-Wattoon, Vice Chair. Present. Representative Franson. Representative Bonner.
Present.
Representative Damath.
Present.
Representative Heinzman.
Present.
Representative Morrison.
Present.
Representative Pryor. Representative West. Oh, I missed Wozliak, I'm sorry. Representative Wozliak.
Present.
Representative West.
And a quorum is present, and so I may have a motion to approve the minutes of our first meeting of the committee. You just say so moved if somebody's willing to do that. Representative Katiza-Wattoon moved approval of the minutes. Any additions or corrections to the minutes? Seeing none, all in favor of approving the minutes, say aye.
Aye.
Any opposed? And the minutes are approved. So a few other housekeeping type points, members. We've got the committee rules are in your packet. There's also committee roster. Certainly if you see any corrections or additions to the roster, please speak up. And if you have any questions about the rules, please do so as well for that. And then I think that with that, we are ready to move to our presentations. We heard on Tuesday about brain development, so we're sort of starting from the beginning, and now we're going to build on that by hearing from two of our agencies about work they're doing in the area of prenatal care and birth. In future meetings, we're going to be hearing about other aspects of early childhood, but we're going to be starting with our Health and Human Services angle, in particular in those the earliest stages, prenatal care and birth. And so I believe we are starting with Department of Health and overview of infant and maternal health mortality. If the testifier could introduce herself for the record, and then please begin.
Sure. Thank you, Representative Pinto, members of the committee. Thank you so much for inviting us here today to share this information with you. I am thrilled to do that, and feel free to ask questions along the way.
Okay.
And I'll be toggling back and forth here, so apologies for my
And a reminder to introduce yourself.
Yes, and I am
for the
Susan
record.
Castellano. I'm with the Minnesota Department of Health. I'm the Maternal and Child Health Section Manager at MDH.
And if I can ask, I think maybe if you can position yourself a little more in front of one of the microphones, you're sort of between the two, yeah, just to make sure you get picked up.
Sure. Is that better?
It is better. Thank you.
Great, thanks. So first, I'm going to mention a couple of, and maybe this one towards me, a couple of trends that are not perinatal specific, but are going to show up throughout my presentation. And that is, apologies, I'm having some technical difficulties here. So a couple of sort of trends or changes that are happening in Minnesota, as I'm sure you're all aware. Minnesota is becoming a more diverse state, and that will play out in some of the slides I'm going to share with you. We are also facing an opioid crisis that we didn't have even several years ago, and so some of the data that I'll be sharing is being impacted by that as well. Sexually transmitted diseases, although this information comes from another part of the health department, it's not the area that I work in. It's important to note because it does have an impact on mothers and infants in terms of birth outcomes. We see these on the rise rather astronomically. For example, gonorrhea went up by 28% just from 2016 to 2017. So these are concerns. And as you can see from this slide, coming out of our folks in the chronic disease, suicide, alcohol-related deaths, as well as opioids and other drugs, deaths from these factors are all on the rise as well. And as things go for the general population, so they often go for moms, pregnant women. So a little bit about infant mortality. And I'm going to start by telling you first that we have about 70,000 births a year in Minnesota. We have about 350, give or take, infant deaths a year in Minnesota. So Roughly an infant a day dies in Minnesota. And I'll tell you a little bit more about the definition of infant death in a minute. Roughly 2/3 of those are within the first month of life. And we lose to stillbirth about 400 or so infants a year. And so it's an important issue that is impacting our families. So I'll be talking a lot in terms of rates throughout this presentation, rates per 1,000 births, rates per 100,000 births. So I'll try and make a distinction when I'm talking between rates and percentages because they can look the same. So the infant mortality rate is expressed as a number per 1,000. So if there were 346 deaths, as there were in 2014, for example, that leaves us with an infant death rate of 4.9 infant deaths per 1,000 live births.
And Ms. Castellano, I'm going to stop you.
Yep.
I think perhaps in our packet that maybe there was a double siding. I don't know that we have these slides unless other folks have seen that. So just so you know that that we have some of these slides and maybe not others just because of a packet challenge.
Okay.
So or at least maybe I'm letting members in the public know that as well. So.
And so feel free to stop me or have me go back if you run into a question on something I'm sharing. So, death is death for any reason, any cause within the first year of life. That's what constitutes an infant death. Causes could be sudden infant death syndrome, or SUID as we now call it. It could be a car accident. It could be death shortly after birth due to profound birth defects. It could be any of those things. Fetal death, on the other hand, which I'll also talk about, is death in utero. So the infant was born without having taken a breath. That's where the line between fetal and infant is drawn.
Ms. Castellano, how does our rate compare to other states? Maybe that's what.
I'm so glad you asked.
Okay, perhaps maybe that's what's on this slide. I can't tell.
Well, and this one is a look at all many of the developing countries in the
Okay.
world. And as you can see, we rank 29th. We have an infant mortality rate in the U.S. of about 5.9. Countries like Finland, Iceland, Norway have achieved rates of 2.2 per 1,000. Less than half of the rate that we see happening in the U.S. So we're not keeping up with the rest of the world is the takeaway from this slide. And while we've made some improvement in the U.S. over the last years, you can see this is from 1996, we've still got a long ways to go. Minnesota is a little bit better. You see we're the 5 deaths per 1,000 there compared to the 5.9 deaths, but still double the rates that we see in other developed countries. Mm-hmm. And then within Minnesota's rate, here is a look at the infant mortality rate by race and ethnicity of mothers. So as you can see, even within that 5 deaths per 1,000, it is not distributed equally across our population. African American, American Indian women experience rates that are, in some cases, 2 to 3 times higher than the regular, the overall rate in the state of Minnesota. As to causes of death, congenital anomalies make up about 1/4 of them, but as you can see, for African American and American Indian women, those are eclipsed by prematurity as a cause of death and obstetric conditions, so various health conditions that cause the infant demise. And correlated to that, fetal mortality, or stillbirths as they're sometimes called, rates again, for us compared to the U.S. are better. This is Minnesota stillbirth rates, but you can see that the U.S. runs about another point or 2 per 1,000 live births above us. However, stillbirth rates by race and ethnicity in Minnesota again show the disparities that we're concerned about. So. African American, American Indian women experience rates 2 to 3 times higher for fetal deaths than does the overall population in the state. And because we're talking rates so much, just one more point. So we get essentially a phone call a day in our office of an infant that's died every day of the year, throughout the year, to send out information to the families. And so it's a very real issue, and it has a profound impact on families. There's research demonstrating that, of course, the loss of the infant is in itself a horrible occurrence, but the family results, the chronic disease, the depression, all the things that follow in the wake of losing that infant have a huge impact on society as well. So one of the tools that it's used nationally to look at this issue is a fetal and infant mortality review. This is a surveillance tool that's used to developed by the American College of Obstetricians and Gynecologists and the Maternal and Child Health Bureau, the feds, and used to identify or get behind the causes of death for infants and fetal deaths. And we used to have statute in the state of Minnesota that allowed the Department of Health to gather that data. That statute was removed. We now only have maternal death statute that allows us to look at maternal deaths. What we did do there was one fetal and infant mortality review done in 2008, or published in 2008, for American Indians, looking specifically at their issues. And it really served for years after to guide both our work and work in the community. Children's Hospital, for example, added an American Indian liaison to their staff as a result of this when they looked at what some of the issues associated with the deaths that they were seeing created. So it was very widely used, very widely appreciated, and now that's been 10 years ago. So we don't get the chance to routinely do this because of statute and resource limitations.
Ms. Castellano, what you said it was about 10 years ago that the authority and resources went away for this?
Right.
And I'm just trying to think, because 10 years ago, I mean, was it a budgetary issue at that point?
I think, no, it was really a look at the fact that it was a little used statute because it had never had funding that accompanied it, and because I think there was a desire to remove from the books things that weren't actually happening. It really came down to that. The maternal language that was in the same statute stayed there because those were ongoing.
Thank you.
Mm-hmm. So a fetal and infant mortality review, just really briefly, the idea is that cases are de-identified. It includes a family interview, so you learn what happened from the family's perspective, which is, of course, otherwise not captured in any of the data. Clinicians, usually OBGYNs, review the cases and create a de-identified summary of each. The case reviews, there's then formed a case review team, multidisciplinary team, that reviews these cases looking for trends, underlying causes and issues, and makes recommendations. And those recommendations are then used by a community action team to look at system changes in the community, policy changes, service changes, that sort of thing. I'm not going to go into great detail of that, but it's a very robust and useful tool that engages the community in addressing the issue. It isn't just data. Now I'm going to talk about maternal health a little bit. And one slide I'm going to share that is a sort of good news slide, because I feel like lots of my slides have sort of unfortunate or information that's not very happy. This is one happy note. Minnesota's teen pregnancy rate, as is true across the country, has decreased significantly in the last several decades and continues to decline. That's good news because teen pregnancy has poorer birth outcomes for the infant themselves, but is also often not a situation where the teen is well resourced to care for the child. So that is good news. Unfortunately, that rate is not equally distributed. Again, we see disparities by race and ethnicity in the rate of teen pregnancy. So while the rates are going down, the gap persists. Talk a little bit about preterm births. As you saw from one of the earlier slides on infant mortality, preterm birth is one of the leading causes, and in some communities, the leading cause of infant mortality. But of course, for infants who live, prematurity also creates a number of problems, cognitive and physical, because development wasn't optimal. And so preterm births are something we care a lot about and would like to see decreased. Here are the rates, and as you can see, by race, ethnicity of mother, they vary dramatically. American Indian women, again, seeing the highest rates of prematurity. And percent of unintended pregnancies, we talk about this because one of the best strategies to promote good birth outcomes, we know, is family planning, is for pregnancies to be intended in the first place. And because it means that the people have the resources and have decided that they have the resources to support the babies that they're having. So Minnesota PRAMS data shows us this information, and as you can see, the disparity, fairly significant disparity here between planned and unplanned pregnancies by race, ethnicity as well. Nationally, we've seen a great deal of improvement with the expanded use of long-acting reversible contraceptives, or LARCs. They are much more effective and have been shown to reduce teen pregnancy dramatically. I think it explains a lot of that curve that you saw. So maternal depression, I'm going to spend a couple minutes on this because it's really important. So pregnancy and postpartum are a very vulnerable time for maternal depression, and depression is a bad thing no matter when it occurs to you, of course. But it's particularly important because it is in fact the leading cause of death, which we'll show you later. It is actually, as Dr. Gunner was saying on Tuesday, it also has an impact on the infant. So while you may be an adult without a baby, an infant, and think, well, I'll just eventually get over this, if you're an adult with an infant and you're the primary caregiver doing the serve and return that Dr. Gunner talked about, and you're not in the loop, getting that taken care of sooner rather than later matters, because you're hitting and passing those developmental windows that child has. And so children raised by chronically depressed mothers, research demonstrates, often perform lower on cognitive, emotional, and behavioral assessments. And so the screening and timely addressing of that is important. And as I said, it's also the most, the one single largest cause of death, as you'll see in a future slide. So this slide takes us a step back and recognizes that, much of our health, as Dr. Gunner alluded to as well on Tuesday, is not due to clinical care, but rather a result of health behaviors, physical environment that we live in, and the other aspects of the environment we live in, social and economic factors, and really genes, your genes and biology and clinical care, the things we think of as determining our health, are really only a small part of what makes up health. For that reason, I think you've all seen various models evolving, and Hennepin Health and Dakota County are examples of that. People who are trying to address people's health more holistically by identifying the social factors impacting them and trying to get them to the services and resources that they need. That's a lot to ask of the healthcare system, though, and so we in Minnesota are fortunate to have a local public health system and county system that is very, very well grounded. Many states don't have those local service entities, and so I think we have to remain mindful about how we pull them into solving some of the social determinants of health problems, rather than always making that something we're expecting healthcare providers to solve. And this is just another way of looking at all of the various things that impact ultimately our health and well-being, as well as the health and well-being of mothers and children. Now I'm going to share a little bit of information from our Pregnancy Risk Assessment Survey, or PRAMS as it's cleverly named. This is a national surveillance project between states, including the state of Minnesota and the Centers for Disease Control, and it's a population-based survey of women who've given birth shortly after they've delivered, that asks them questions about their behavior before, during, and immediately after birth. So this gives us data that really doesn't come in on birth and death certificates and isn't available anywhere else. So to the point about stressors and all the things that make up health, the PRAMS survey asks women about stressors that they experienced while they were pregnant, and I'll talk a little bit about what those are in a minute, but just a slide to show you that, in fact, the experience of those stressors, and particularly 5 or more of them, we have disparities in that. Our U.S.-born African-American and American Indian folks who we oversample for in the survey experience much higher rates of stress or multiple stressors than other portions of our population.
Ms. Castellano, can you give some examples of when you say the stressors? Maybe you did, maybe I just missed it.
So
but-
sure, it can be food insecurity, housing, oh gosh, any number of things. Money, financial problems, job issues, death of someone in your family, things like that. You know, they're not specific to pregnancy, but they impact the pregnancy.
Thank you.
Mm-hmm.
And Ms.
here are
Castellano,
some-
hold on one moment. We have a question from a committee member, Representative Bonner.
Sure, Representative Penland.
Mr. Chair, I'm just curious on this chart. We're breaking this down particularly at the moment by ethnicity, but I'm curious, and certainly there may be greater economic insecurity in some of these populations, but I'm curious how that breaks down by economic status or poverty or that kind of thing, as opposed to this, because I'm wondering if that might be a stronger factor.
Ms. Castellano.
So we do, Representative Pinto and Representative Bonner, we do look at it a variety of ways. We look at it by maternal age. We break it down by geography. I have a lot of other data that I didn't include in this slideshow for today. We don't gather socioeconomic data. We can break it down by poverty, though. We do have a sort of yes-no trigger for poverty, and so I would be happy to share that information with you. Can forward that
Thank you.
to the committee.
Thank you, Mr. Chair.
Thank you. Ms. Castellano.
Thank you, Representative Pinto. Here are some of the categories of stressful life events that get reported on that survey. So if you moved during that time, if you were homeless during that time, if you had problems paying rent, mortgage, or other bills during that time. Others include husband or partner loss of job, cut in hours or work pay. And so these stressors are important because there's a lot of information, and I think someone asked in the committee on Tuesday, alluded to the epigenetics of all this, the idea that the stress does have an impact on the pregnancy itself. And in fact, there's research on infants whose parents experience that stress that demonstrates cognitive, neurodevelopmental, and other functions. There's actually research demonstrating that it in fact perhaps wires that infant's brain differently in the womb. That process that Dr. Garner was talking about for young children actually starts even in utero. And so it's important, stressors have an important impact on birth outcomes all the way through adolescence as it's been measured. So I'm going to talk a little bit now about prenatal care. And prenatal care, the Healthy People 2020 goal was 77.9. I'm not sure how they arrived with a goal with a decimal point in it, but that is the Healthy People 2020 goal. And as you can see here from trends in Minnesota, we only the white population in Minnesota meets that goal. That's the line that is the top one on this bar. I won't describe it by color. But here's a perhaps more interesting slide that breaks that down. And you can see where the differences exist by race and ethnicity. And while we're seeing a general decline in prenatal care in the first trimester across the state, it's being driven not insubstantially by the African American, American Indian decreases that you see represented in this slide. And so prenatal care is necessary but not sufficient, right? Prenatal care is important. We discover things. We encourage people to take folic acid and do things that are preventive of birth defects and other things. But prenatal care alone doesn't solve that problem. And again, this is a breakdown of people who did and didn't get prenatal care in the first trimester. And I've got the list of barriers to care that they experienced. So this was things like couldn't get transportation, couldn't get into the clinic, I couldn't get an appointment when I called, couldn't Didn't know I was pregnant, things like that. And actually, I've got a slide on that, so I'm getting ahead of myself. Here are the barriers. Didn't know I was pregnant was actually a substantially high number in the U.S.-born Black and American Indian populations as compared to other groups in the survey. Didn't have enough money to pay for visits or insurance was also a factor. And interestingly, the transportation issue is particularly hitting American Indian mothers, presumably because that's folks who are on reservations and not in the metro area. Although that survey doesn't include only them. So, but looking at women who did receive prenatal care across race and ethnicity, did receive prenatal care in the first trimester, as you can see, that it doesn't mitigate the disparities that ultimately occur. So these are the infant mortality disparities by women who received care in their first trimester. And as you can see, the disparities are still significant for African American and American Indian women. I'm going to talk a little bit from the PRAM survey about experiences women have after they're born. So as we know, and as Dr. Gunner conveyed Tuesday, having supports when you have a new infant is important. Having around you what you need, both physical, emotional, and so forth, is important. And here's a look at questions in the PRAM survey about whether you had supports after pregnancy. Is there someone who could loan you $50 if you needed it? Is there someone you can talk to about your problems? Is there someone who can help you if you were sick and needed to be in bed? And there is variation. These numbers are all fairly high, but there is variation by race, ethnicity. Others are things like, would there be someone available to take care of my baby? Is there someone to help me if I'm tired and feeling frustrated with the new infant? So those support systems are crucial and experienced in variable degrees by different folks in the community. And then I'm going to finish up with a little bit of information on maternal mortality. This has been in the news a lot lately. If I had a dime for every time we got a media call about how this issue, as it's played out on the national front, is happening in Minnesota, we'd have some extra money around. And unfortunately, so here's what's happening to the rates. And we're not sure why this is happening exactly at the U.S. level. A couple thoughts are that we actually are doing a better job of case finding. We're identifying more pregnant women, or identifying that they're pregnant when they died. So case finding is definitely improving. But we are also seeing an increase in pregnant women who have chronic conditions, diabetes, hypertension, and the like. And we know those are risk factors for poor birth outcomes. So the chronic health of our country is playing out in the outcomes of its pregnancies. Just a really quick word about maternal mortality definitions. Maternal mortality is a birth that occurs when a woman is pregnant or up to a year after labor and delivery, regardless of the cause. A more narrow, that's pregnancy associated, a more narrow definition is pregnancy related, and people calculate this different ways. So I'm going to be jumping back and forth between them based on what data is available, so I apologize for that. So here's a look at the causes of pregnancy in the United States. Cardiovascular diseases top the list, non-cardiovascular diseases like hypertension, infection or sepsis, hemorrhage. The focus nationally has been on women dying in the hospital during labor and delivery, but in fact, that is a small portion of the deaths that are actually occurring. Here's a look at causes of death grouped more broadly in Minnesota, and as you can see, suicide is 8% of those deaths. Obstetric complications, when they're grouped together, which is a lot of things, is about 18%. Non-obstetric complications, violence is 10%. And then there are other things that were perhaps not specifically related to the pregnancy. We experience about 20 maternal deaths a year in Minnesota. It's a very small number, thankfully, But it also means it's very hard to talk about trends, especially when you start breaking it down by causes. And so this is data from multiple years, as you can see. But we get asked, is the hemorrhaging in hospital, hypertension, stroke in hospital, is that happening at a greater rate here in Minnesota than elsewhere? And we don't think so, but we can't really answer that question. Some states gather morbidity data, so in other words, severe morbidity events where a significant event occurred, but the woman didn't in fact die from the event. That provides a lot more data. We don't have statutory authority to gather that, nor do we have the resources at this time, but it would make our data more robust. And so we do conduct maternal mortality reviews. So this is a situation where we gather all the cases in the state that we know of. A clinician conducts a medical review of each case, develops a summary that is de-identified, and then a review team assembles 2 to 3 times a year to review these cases, identify causes and trends, and look for factors. Some states, as I said, include morbidity. That is not included in our state. And here's the Minnesota rate with a number, across a number of years. I just want to caution you that these numbers are very preliminary. And as you can see, because of the small number, the rate jumps around dramatically from year to year. And this is for all maternal deaths. So if a woman is in a car accident when 9 months after delivering an infant, she will show up in this data.
Bless you.
So in the U.S., there are disparities, considerable racial disparities for pregnant women, over 3 times the rate for white. And this does not have American Indian in it. The national statistics do not. Minnesota statistics are very stark. This is portrayed as a rate because the numbers are so small, but the visual tells the story here. The American Indian rate is in fact close to 4 times as high as it is for white women in the state experiencing maternal deaths. And here's a look at, here's a look at the proportion, or sort of the burden, if you will, of maternal death across different groups. So the proportion of births, about 72% of them are white, and then you can see that on the right-hand side there, the division by other racial and ethnic groups. While American Indian women experience 2% of the births in the state, they in fact experience 12% of the maternal deaths in the state. Likewise, it's an elevated rate for African American women, and reduced, obviously, for white women in Minnesota. And then last but not least, a little bit of a geographic distribution. So this is hitting us all over the state. And the physical location of death, as you can see, hospital, inpatient deaths, and or ER are really only half of the story. There are many other locations, including at home or en route, that are locations of these causes of death as well. And the split is about 50-50 rural, urban for maternal deaths. So that is just a very, very brief overview of some of the statistics we have in our area, and I would be happy to answer questions from the committee.
Questions, members? Representative Cortez-Wittoon.
Thank you, Mr. Chair. Ms. Castellano, I'm just trying to find the slide, sorry. The one about, oh yes, the adequacy of prenatal care from 2010 to 2016. There's like a drastic drop for the American Indian category. And I'm just wondering, do we have any further data on the barriers to care and increasing in some of those areas? I mean, people obviously not knowing they're pregnant is an issue. They're not going to go get care. But I mean, the transportation seems to disproportionately affect the American Indian women, as you mentioned. And has transportation access gone down? I mean, it's almost a 10% drop in adequacy of care, and it's just staggering to me.
Yeah.
Ms. Castellano.
Representative Pinto. It is interesting. The numbers are so small. As you can see from this slide where we talk about barriers, we had to pull 3 years together to have enough information to talk about it. So we don't really know that. And these questions are fairly new. Actually, addition to the survey, we don't have that many years of the questions available. I'll look into that, and if there is a way to talk about trend at all, I will get back to you on that.
Thank you, that'd be wonderful.
Other questions, members? Oh, Representative Pryor.
Thank you, Mr. Chair. And just to go back again to the part of your presentation when you're talking about infant mortality and when, the statement, some of these deaths are preventable. So can we hear more about the preventable deaths and infant mortality?
Sure.
Ms. Castellano.
Representative Pinto. Certainly one really good example is infant deaths from suffocation. So what people have typically called SIDS, but we now refer to as sudden and unexpected infant deaths, or crib deaths as they're sometimes referred to. We see about 50 or so of those a year. So those are almost entirely preventable. And it's unfortunate because it's an education issue. We've heard stories of parents who say, well, I heard that I wasn't supposed to sleep with my baby in bed, so I slept on the couch with my infant. And in fact, that's an even more dangerous place because they can become entrapped between the cushions and you and that sort of thing. So we can't do enough education on this issue, and we can't be clear enough about what we mean by it when we do it. Others that are preventable, I mean, the prematurity is a huge contributing factor. If we reduce prematurity, we reduce the number of infants who die because they weren't able to survive at the point that they were born.
Representative Cortez-Butune.
Thank you, Mr. Chair. Just to follow up on that, the sudden unexpected infant death. So I'm a certified foster parent in Hennepin County, and we're required to watch some videos on SUID and continually watch that to maintain our certification. I'm just wondering what sort of partnership we've looked into with some of the some of the OBGYNs. Representative Morrison, maybe you can speak to that. I know we can't mandate that parents watch these videos, but do we show them in the waiting room? Do we give them some type of additional access so that they're getting that information on a greater scale?
Representative Pinto, we do. We work with hospitals specifically. It's a tough time because it's when everybody wants to deliver a message to mom and she's just had a baby and it's all a little overwhelming, but we do ensure that information is shared with them at the hospital and also that it goes home with them. We're working with hospitals around the state to become Safe Sleep certified, which means they're modeling safe sleep behavior because sometimes hospitals do things because it's the hospital that you don't necessarily want to replicate at home, and they have to be sure to communicate that. For example, swaddling an infant longer than they should be swaddled. It's fine when they're a newborn, but when they need to be able to roll over, it could in fact create a situation where they can't, their face is in some bedding and they can't move. And so, swaddling's become popular. People didn't do that 10 years ago, but so now we have another education issue we have to address.
Representative Pryor.
Then and I think maybe the expertise is on our committee too, but talking about preventing premature deaths, infant deaths. So what are some of the key points we should remember about premature births?
Ms. Castellano.
Representative Pryor, thank you. Yes, prematurity, actually one of the projects that we're currently working on is implementation of 17P or alpha hydroxyprogesterone. We've got some quality improvement projects working to deliver this drug to women who've had a previous preterm birth because it reduces by about a third a subsequent preterm birth. It's one of the few short-term or quick fixes we can do. I mean, a lot of solving the preterm birth problem are long-term solutions addressing the health of the women. Preconception health has been shown to have a huge impact, larger than prenatal care. A woman going into a pregnancy healthy is a great predictor of how healthy the pregnancy will be. And but those things are public education issues that take longer. Clinically, we don't have a lot of tools in our toolbox left, but 17P is one of them. So.
Oh, and Representative Weiselbeck.
Thank you, Mr. Chair. Ms. Castellano, I'm wondering if you, there's the slide about the stressors. Some of those things make sense, but some of them I'm wondering if there are other factors that lead to those stressors. Is that anything that there's been research on from Department of Health, or is that more something that we don't know enough about? I'm thinking of pregnancy discrimination in jobs, things like that, if there's anything that we know about background about why those other things occur.
Ms. Castellano?
Representative Pinto, that's a great question, and we don't know what goes behind those. I mean, racism is another example. It could be playing into many of these factors, but it's not captured there. So the chronic stress has a huge impact on birth outcomes, but very difficult to measure. So we don't have anything further in our data behind that.
Ms. Castellano, to your point about, you mentioned racism, mentioned impact on pregnancies, et cetera. My understanding from national studies is that, even that women of color actually have, worse outcomes in pregnancy or higher maternal mortality, even controlling for education, income, et cetera, depending on where they live. And so it's sort of actually there's been research that actually teased out some of those factors that indicate that there probably is sort of racial factors in society. But can you just comment on that just a little bit more?
Yeah, Representative Pinto, I'm happy to do that. There's long been what's been called the weathering effect that people have studied for birth outcomes in the African American community. So even when all other things are the same amount of education, same amount of access to resources, African American women have poorer birth outcomes, and they particularly decline with age, which they've not been able to explain either. And so research has started trying to tease out nationally the impact of race, and they believe that chronic stress load, that allostatic load to your body over time, in fact, does have an impact. The other is that, so as we learn more about epigenetics, right, and the fact that multiple generations impact your outcomes, you're studying someone in their current state, but it really isn't taking into effect that cumulative effect that's occurred over time.
Representative Morrison.
Thank you, Mr. Chair. Ms. Castellano, thank you for your presentation. You've referenced a couple of examples where you either don't have the statutory authority or the resources to measure different variables. I'm wondering if you could share with us which would be most useful to you and to us in terms of trying to address these disparities.
Representative Pinto, thank
Ms.
you.
Castellano.
Thank you. Certainly, we have one staff person who's responsible for infant mortality in the state. She spends her time running these numbers, and she spends time attending meetings as she can and encouraging the Safe Sleep Hospital project that I mentioned, as well as sending out materials to families who need them. We don't have much of any resources in terms of education activities for this work. We also particularly don't have statutory authority, as I mentioned, that did exist and went away, to do fetal and infant mortality reviews. And of course, they take resources. When we have case reviews, those are done by clinicians that are really largely volunteering, but are paid a token amount of a stipend to do those case reviews. And then on the maternal side, it would provide us much more robust Minnesota data if we were able to look at the morbidity as well as the mortality for mothers, because the numbers are so small, and do similar case reviews. Other states have done that, where they take at least a sample of that morbidity to see what's really going on behind those outcomes. And we do not have the staff or resources to do that. Thank you.
And just one quick follow-up on that. You mentioned that there's not a morbidity review. Some other states have that. What are we lacking in not having that? What kind of an impact would that have to have that?
Representative Pinto, I think that would give us better numbers. So for example, if a hemorrhage or hypertension occurs, it doesn't always result in death. A woman may end up having a stroke that impairs her for life, but she doesn't show up in these maternal death numbers because it was a morbidity, not a mortality. So I think it would help us monitor trends, because we'd have a larger number of incidents to look at, and it would help us understand the broader impact rather than death being obviously the worst outcome.
Okay. Any other questions, members? And not seeing any. Ms. Castellano, thank you very much. We
Thank
really
you.
appreciate it.
Thank you for the opportunity.
Thank you. And we'll call up our testifier from the Department of Human Services. As the testifier comes up, I'll just note again that we, having a healthy, thriving child, the very first step to that is a healthy pregnancy and healthy birth. And so I really appreciate the agencies getting our committee's work off to a good start here. Maybe as we get settled in, Representative Franson, we had, the other day, folks had just introduced themselves, just their area they're from and their connection with an interest in this work. I should just note for the record that I'm lucky to have, as the lead on the committee, somebody who has great legislative expertise in this area. You chaired the most recent committee that focused on aspects of early childhood, and then professional expertise, and I bet you have personal expertise too. So Representative Franson, if you wouldn't mind just introducing yourself to folks.
Thank you. Representative Mary Franson, I hail from District 8B, Alexandria there. I'm serving my 5th term, and as Chair Pinto did say, I did chair the Subcommittee on Childcare Access and Affordability the previous 2 terms. I am a former licensed childcare provider, so I bring that expertise, and that is my passion, is to make sure that we have access to privately run childcare. We see a lot of competition taking place with the government programs versus the private industry. Private industry is in peril right now. It's being forced out, and it's creating a big access barrier all over the state, including greater Minnesota. And also, right now, I'm really digging into the childcare, the CCAP, the Child Care Assistance Program with the fraud, and really digging in there, and I'll be bringing forward some bills, Mr. Chair, to deal with that fraud, to make sure that we bring integrity back into that program. So I'm very excited. I think that we have a really stellar team here, and I appreciate those in the crowd that have traveled to here as well. That childcare is also their passion. So thank you.
Thank you, Representative Franson. And so if the testifiers could introduce yourselves, I'm not sure who's going to be going first, and then begin your presentation.
Good morning, Chair, committee members. My name is Heather Peterman. I'm the lead for the Healthcare Research and Quality Division at the Department of Human Services.
Good morning, Mr. Chair, members. I'm Karen Justo. I'm a Healthcare Eligibility Policy Manager at DHS.
And good morning, my name is Giogo Hayes. I'm a manager in the Purchasing and Service Delivery Division at the Department of Human Services.
And would you mind, sorry, just spelling your last names for the record so we make sure that our minutes reflect it properly? So just providing your names with the spelling of the last name if you can.
My name is Heather Peterman. The last name, as you see on the slide, is Petermann.
Oh. And I'm so sorry, I noticed, are your names on this first slide? My apologies. I hadn't noticed that. Then no need to continue with that. And please begin the presentation. Thanks.
Thank you, Representative Pinto. Well, the focus of our discussion is the Medicaid eligibility programs for women and children. I thought it'd be helpful to start just with a broader context because as we have heard and as we know, children are part of family unit structures, and if the health and well-being of their parents and caregivers and others in their household are at risk, so is the health and well-being of that child. Minnesota state health programs, including medical assistance and Minnesota Care, help lessen one of those stressors of access to affordable health care coverage for 1 in 5 Minnesotans. Our Minnesota Medical Assistance Program is part of a long-standing state and federal program that covers a full range of demographics and services. That spectrum of age and services is a helpful reminder that kids in our current demographics are the seniors and aging adults 60 years from now. And also that the health and needs go beyond birth and childhood when we're thinking about overall health. For example, 17% of our kids live in households where at least one of them in the household has complex chronic conditions, or 13% of parents have a serious mental illness. If we look at who is enrolled in medical assistance, which you see here on this slide over time, in 2017, approximately of the 1.1 million enrolled, parents and children, which are that largest category in blue there, make up the biggest portion at 700,000. Although they make up 65% of the total number of people that are part of DHS's healthcare programs, they are approximately 25% of overall healthcare service expenditures. Taking a deeper dive into just that blue category that you saw there of parents and children, we can see that children are the single largest group in Minnesota Medicaid's program, making up 45% of our enrollment. These children are all across Minnesota's counties. Parents and pregnant women are included in this overall group. In the other category that you see there, these include some special programs such as breast and cervical cancer care, those formerly in foster care, and Minnesota's family planning program. The enrollment numbers here that are on the blue are contrasted with the average monthly amount spent on healthcare services received for the people in these enrollment groupings. The summary point is that the Medicaid program plays a critical role in the health of Minnesota's children, providing coverage to 42% of the state's kids under the age of 20, and approximately 43% of all births in the state of Minnesota are covered by Medicaid. My colleagues will be discussing the services that are specific to pregnant women and children in more detail. But I wanted to just highlight that when we're talking about healthcare coverage, we are referring to a comprehensive range of services, including behavioral health, outpatients and inpatient surgeries and services, specialty care, pharmacy care, transportation, dental, et cetera. You can see how those service categories break down in this slide here and compare the overall spending for various populations. The most intense are services for children from birth to age 5, which you see on the left. Note, for example, if we compare that to the average spending of $1.7 billion for all children from the previous slide, 42% of that is spent in the first 5 years of life. We recognize that there are many social service supports and factors that interact and play an important role in a child's health and well-being, but certainly ensuring access to affordable quality medical care is a part of that picture. And so I'm going to turn it over to my colleague, Karen, who will talk about the process for becoming eligible and enrolling in medical assistance.
Okay, so a bit about the nuts
Excuse me,
and
actually,
bolts.
pardon me, I'm going to have, if it's okay with the testifiers, to have some questions along the way. I think that'll be helpful, at least some clarifying questions. Representative Wasilwick, I believe, has a question. Oh, it is Representative Morrison. Pardon me, Representative Morrison, wasn't sure.
Thank you, Mr. Chair. Ms. Peterman, I'm wondering if you have the breakdown of the inpatient hospital care, what percentage of that for 0 to 5 is neonatal intensive care unit?
Ms. Peterman.
Chair and Representative, thank you for the question. We do have that breakdown. I don't have that number off the top of my head, but we'd be happy to follow up.
Thank you.
Please continue, Ms. Giusto.
Okay, I'm going to talk a little bit about the nuts and bolts of medical assistance eligibility. This slide, we call this our continuum, our healthcare continuum. And you can see over on the left in blue is our medical assistance program. Right in the middle, there's a little purple box. That's our Minnesota Care program, which serves people whose income is, certain people whose income is too high for medical assistance. And then over on the right, that is eligibility for people who purchase qualified health plans through the exchange and then can qualify for federal tax credits for that coverage. And then we give you some of the numbers so you can take a look at what those FPGs correlate to with regard to dollars. Program eligibility for medical assistance is determined by many factors, including things like the family size of the applicant, the household income of those family members, but also personal factors such as how old I am, my age, am I disabled or not, am I pregnant or not. And you can see that the income standards vary based on the population that a person might fall into. The income standards for children and for pregnant women are higher than the income standards under medical assistance for some other populations. So what are the factors that we look at in determining eligibility for a pregnant woman under medical assistance? Well, a pregnant woman, we define this group as a woman who is pregnant, and that can go as early as the first day of the month of conception throughout her pregnancy, and then ending the end of the second month following the end of pregnancy, so 2 months postpartum. So a pregnant woman could qualify for medical assistance for 11 or 12 months, depending upon when she enters the program. She must have income at or below 278% of the federal poverty guideline, and this equates to roughly $45,700 annually for a family of two. A pregnant woman is always considered at least a household of two because we count her and we count her unborn in that equation. She must eligibility continues for pregnant women throughout pregnancy. So we call this continuous eligibility. If I'm a pregnant woman and I'm determined eligible for medical assistance, regardless of income changes that may happen during my pregnancy, I'm entitled to that coverage until that pregnancy ends and the 2 months postpartum. She must meet non-financial criteria as well, which apply across medical assistance, things like she must be a resident of the state of Minnesota, for example, and other criteria. We're often asked about asset tests, so I put this on the slide. There is no asset test for pregnant women or, in fact, for any families with children. So we don't gather information about bank accounts and things that she might own. Her eligibility financially is based on the income. Moving on to eligibility for infants and for children. For newborns, children who are born to mothers who were enrolled in medical assistance at the time of the birth, those children have automatic eligibility under medical assistance through their first birthday. So they're automatically eligible for all of those critical services that they need in the first year of life. Once that baby turns age 1, she may qualify for medical assistance under our infant group. And this also would include babies who are born to mothers who were not enrolled at the time of the birth. And to qualify under that group, that infant must be in a household with income at or below 283% of poverty, which equates to roughly $46,500 annually for a family of two. And our infant group is our highest income limit in Minnesota. That's the highest limit we apply to any population under Medicaid. At age 2, that baby would move into our children ages 2 through 18, which is our third highest income limit. And that child may qualify with household income at or below 275% of poverty, which is roughly $45,200 annually for a family of two. And then our eldest child group is children ages 19 and 20, and that income limit is 133% of poverty, roughly almost $22,000 annually for a household of two. And that 133 income limit is the same income limit that applies to parents and also applies to adults over age 21 who are not disabled in MA. All of our eligibility categories, all folks under Medicaid are required to meet non-financial factors such as being residents of the state of Minnesota as well. So how does one enroll in medical assistance? Well, medical assistance is our state's Medicaid program, but it is a county-administered program. So our boots on the ground for medical assistance are our county and tribal agencies, our frontline financial workers. People may apply online on the MNsure website. If they apply online, that information that they put in that online application then gets routed to their local county agency for case management and handling. They can also apply with a paper application, which they can return to their county, they can return it to DHS, their tribal agency, they can mail in applications, fax them, or drop them off. Application help is available, again, through our local county agencies, tribal agencies, DHS here in St. Paul. People can also connect with the MNsure Contact Center, and they will find help for them as well, and there are navigators and brokers out in the community. Once a person has submitted that application and their eligibility has been determined, they do receive notices that tell them about their eligibility. They receive new member, what we call welcome packets, that give them information about how the program works. They get a Minnesota Healthcare Programs ID card, and if they're going to be receiving their services through managed care, they receive managed care enrollment materials as well. Speaking of managed care, about 75% of the people who are enrolled in our public health care programs receive their services through our state's contracted managed care organizations, which include both health maintenance organizations, HMOs, and county-based purchasing plans. The remaining 25% of our members receive their services through a traditional fee-for-service system, where the medical provider receives payment directly from DHS for the services that they provide to the member. Diogo.
Thank you, Mr. Chair and committee members. I'll talk a little bit about some of the services that pregnant women and children can receive in the medical assistance program. Some I think are services you specifically asked about, and I added a couple that I thought might be of interest to the committee as well. The first slide here talks about mandatory and optional benefits, and this is in context to I believe the question you guys had about early periodic screening, diagnosis, and treatment. And that's a federal concept that appears in the Social Security Act, and I think of that as in two buckets. So the first bucket is related to the part of the EPSDT Social Security Act law that says that children under the age of 21 have to have access to any medically necessary treatment in order to treat any illness or medical conditions that they have. And so the way that plays out is the federal government allows states some flexibility in the way that they decide to design their Medicaid programs. And so as you can see in the slide, on the left side, you'll see mandatory benefits, and this is just a small sample of the more comprehensive list, but things like inpatient hospitalization, outpatient hospitalization, et cetera, are mandatory, and so all populations are required to have those in a Medicaid program. On the right side, though, you see some optional benefits. And so in some states, they have elected not to take up some of these benefits, so they might not have eyeglass coverage, or they might not have dental coverage. But because of the EPSDT requirement in the Social Security Act, that really option is really more on the adult side. So some states might have an adult benefit and a kid's benefit. Here in Minnesota, however, we do have a pretty comprehensive benefit. There are a couple nuances to that, but overall, we have a pretty comprehensive benefit set. So within the medical assistance program, we largely just have one benefit set. And so the early periodic screening, diagnosis, and treatment concept about medically necessary services for kids in Minnesota ends up pretty much being the Medicaid benefit. The second piece related to early periodic screening, diagnosis, and treatment, also found in the Social Security Act, is another requirement for all state Medicaid programs, is related to helping kids get in for things like early periodic screening, diagnosis, and treatment. And so here in Minnesota, what we call that program is child and teen checkups. And so if you're familiar, taking your kids or family members, friends taking kids in for well child visits, that's basically the essence of this program. And so we do basically two large things within this program. One is the state sets sort of what we call a periodicity schedule. It's sort of a schedule of services that a child should get, and that's based on the American Academy of Pediatrics. And these are things like preventative visits. So like it was mentioned before, maternal depression screening is a recommended piece on that periodicity schedule. Height, weight, those types of things that you would expect a child to get in some of those well child visits. And so we contract with about 55 tribes and counties throughout the state that do outreach to families and children on the Medicaid program, letting them know that, hey, this program exists. Do you need help finding a provider? Do you know that your child is about to hit 2? It's about time for them to go in for the 2-year visit. Do you need assistance finding transportation or interpreter services to make that happen? And these are some of the things you could expect to happen at that particular visit. The second major piece of this program is in partnership with our colleagues at the Department of Health, we train providers throughout the state on how to execute some of these visits. And so kind of good process flows, it's a lot of work to do within a 20, 30-minute visit, so helping them identify good process flows, giving them resources on what we call anticipatory guidance or health education pieces, and giving them those resources so they can provide these services to the best of their ability and in a way that meets some of the requirements in the periodicity schedule.
Mr. Reyes, can I just confirm or clarify? So this is applying to the 42% of Minnesota kids who are covered under medical assistance, and then that kind of sets a floor for the remaining, nearly 60%. It doesn't directly affect them, but I would think once you've kind of set that expectation, very often pediatricians and families are going to follow that schedule as well. Am I understanding that right?
Mr. Chair, I think that's pretty well put. Also, there's two things I've heard related to that. First of all, the kind of community standard, if you will, is the periodicity schedule called Bright Futures that's put out by the American Academy of Pediatrics. And so that's kind of the industry standard, if you will. So it's fair to assume that most providers do something relatively aligned with that. And our periodicity schedule is largely based on that periodicity schedule. The second piece, and this is a little bit more anecdotal, but we made some changes in 2017 to our periodicity schedule. In a meeting with a lot of the larger health systems, what we usually hear is that they're interested in ensuring that they're treating all the patients that come into their clinics the same. And so they often prefer not to have two different periodicity schedules. A lot of them use our periodicity schedule for their entire population so that you don't get the sense of like, you're a Medicaid recipient, you're not a Medicaid recipient.
And why not just use the Bright Future schedule? Like, what was the thinking in making changes to it? I'm just curious, as long as you've brought that up.
Yes, Mr. Chair. We do a pretty extensive review, again, with our partners from the Department of Health when the Bright Future schedule is updated. It's been updated 4 times now. And some of the recommendations just often do or don't particularly apply to a state. So, for example, we opted, for some things that they tell you to test and see, like, what is the prevalence of that particular disease or something in your state. And so sometimes the state might kind of meet that barometer, and sometimes the state might not.
Okay, thank you.
Another service I believe you asked some about was doula coverage. The Medical Assistance Program in Minnesota does cover doula services and has been covering them since 2014. We cover visits with doulas and pregnant women for pre and post delivery. We also cover a visit for the doula to be present at the labor and delivery. And then we also cover additional visits if requested by the doula or the pregnant mother as well. Another service that helps a lot in this population is, or that's also available to the Medicaid population, is community health workers. Community health workers are trained health educators who can often work to help overcome some cultural or potentially language barriers. And their services provide diagnosis-related health education, which would be ordered by the individual's physician. And so some examples of that might be like diabetes prevention, chronic condition management, help understanding oral health care, those sorts of things. But all those services by community health workers in the Medicaid program center around education on health promotion and disease management. Dental services are covered in the Medicaid program. This is sort of one of those examples of required and optional benefits. It's required for the Medicaid program for kids. We do have a comprehensive Medicaid benefit for kids in Minnesota. Just a tangible example related to that. In the adult benefit, it is a limited benefit. This is one of those nuances I was mentioning where the benefit is differentiated between adults and kids. In 2016 and 17, about less than 40% of kids in the Medicaid program receive dental services. That's compared to the commercial market where you might see somewhere in the mid to high 50%. So that's to say that we have a really significant access issue when it comes to dental services in Minnesota for public programs, medical assistance and Minnesota Care. The department has been working on this issue for several years. At the legislature's request, we've submitted several reports identifying the problem, which is pretty well known at this point, but also identifying some solutions that we think could potentially help that. We're currently under what's called the Corrective Action Plan from the Centers for Medicare and Medicaid Service, and that stems directly from that concept of early periodic screening, diagnosis, and treatment. Because we're obligated to provide medically necessary services to kids under the age of 21, and we're clearly not doing this in the dental space, the Centers for Medicare and Medicaid Services have put us on a corrective action plan to address that issue. So this is a well-known issue and something that we're very concerned about and working on.
Representative Pryor, I believe, has a question. Representative Pryor.
Thank you, Mr. Chair. It just seems like we should, I mean, I heard that. It does seem like a good place to pause, and I do remember in the last session, actually, what I was hearing most often, and you can correct me if it's a bigger picture than this, because I know sometimes we only get a little slice of what the reality is out there. What I was hearing from dental providers is that it was the reimbursement rate was what they saw as the underlying problem. But, you know, this is maybe a good time to correct that, maybe put that in another context information that I don't know, or maybe that is right on, I don't know.
Mr. Reyes?
Thank you, Mr. Chair.
Thank you.
Mr. Chair and members, that is mostly correct. There are several issues that I think make the dental issue, the dental access issue exist. One of the main issues is certainly our reimbursement rate. We at the department completely agree that our reimbursement rate for dental services is inadequate. Above and beyond that, though, the system for administering the dental benefit is also complex. As Ms. Justo mentioned, we do work with managed care organizations. We currently have 8 managed care organizations, which means a dentist who often is more like a small business than like a large health clinic, then has to figure out how to operationalize providing services to a person that potentially has 3 to 5 different managed care organizations have to work with. And so we think of the issue as 1, rates, and 2, also the administrative burden, and trying to attack both of those issues at once to see if we can alleviate that and bring more providers into the network.
Mr. Reyes, can you talk about, obviously there's been a transition in administrations, but I mean, are there concerted efforts aimed at what you've just described regarding dental care?
Thank you, Mr. Chair. So in the past, the department has brought forward proposals to the legislature to address this issue. As you know, the governor's budget is still under consideration, so that remains to be seen. We have, as far as the rates issue goes, we do need legislative authority to increase rates. Our payment methodologies are explicit in state law. That being said, we have done things internally to try and address the issue. Most recently, in the 2018 contracts, we did have some withholds with the managed care organizations to help get better access to dental services. So we said we wanted to see a certain percentage increase over the next year, and we have a certain percentage increase that we're looking for the next 3 years. So we are trying to do some things that we can within our authority, but we do need some help and partnership from the legislature to help increase those rates too.
And to your second point about simplifying the process, are there changes that would not require additional funding, but we could just get some policy changes to simplify the process?
Thank you, Mr. Chair. The reports that the department has put out has recommended that we move to what we think of as a uniform administrator. And so, as many of you guys probably experienced through our health insurance, we have our medical services are delivered through one organization, and then there's a different organization that delivers our dental services. And so that's a similar concept that we would like to do with the Medicaid population, partially to help get some economies of scale so that we have one organization with a holistic look across the entire 1.2 million population to really focus on delivering the dental services for individuals. But we do think that that part needs legislative approval or legislative action, so that has been in our proposal in the past.
Okay, thank you. And we'll let you finish your presentation, Mr. Reyes.
No problem. I'm happy to answer questions. Lastly, this wasn't specifically on the list of things I believe you asked about, but I thought I would just put it in here because I thought it might be interesting to the issue that you're looking at. Related to individualized education programs or individualized family service plans, we do help pay for some of those services in the Medicaid program. And so these are for children that are in special education through their schools. And in the instance that a child has in their IEP some services needed that I've listed on the slides here. So for example, physical therapy, occupational therapy, et cetera, medical services, we do help get the federal match for those services when the school is putting forward the state match. So those are some services. Most recently, in I think 2017 data, we spent about $53 million in that space. We did want to mention just really briefly, not to get too much into the detail, but just to let you know that there are some things that the department is doing that looks at some of these pieces kind of more broadly and to help us essentially get better outcomes for our recipients, and that includes obviously pregnant women and children. This was mentioned before from our colleagues at the Department of Health, but we're also doing some work in understanding social risk factors that impact the health of those on the program that we serve. We're also doing some significant payment reforms that help align incentives through the different payment methodologies to, again, help reach better outcomes for our recipients. Specifically in the Child and Teen Checkups Program or the Well Child Visit Program, we've done some concentrated efforts on working on improving the participation rate for adolescents and young adults. I know that's a little older than you guys are looking at, but that's where we see a pretty significant drop on well child visits as individuals are in their teens and early 20s. We're also in the process of trying to develop or enhance our partnership with the Minnesota Academies of Pediatrics and Family Practice to do some clinical process improvements to help them in executing these well child visits. And then I hadn't mentioned the dental withhold, but that was another piece that we're trying to work on, trying to improve the dental access. So I think with that, that concludes our presentation, but any of us are happy to answer any questions for you.
Questions, members? Representative Cotiza-Witun.
Thank you, Mr. Chair. I have two questions. I think, Ms. Justo, the first one maybe would be for you. You spoke about the no asset test, and I'm just curious, how do we verify someone's poverty percentage if there's no asset test? Is there some other type of structure that allows us to do so?
Mr. Chair.
Ms. Justo, pardon me.
Thank you, Mr. Chair. Representative. Yes, financial eligibility is based on income.
Okay.
So monthly income, your current income. So we're looking at wages, self-employment, and applicants verify that. We verify that. We attempt to verify that electronically through some data matches that we have with the federal government. But then if we're unable to do that, we verify that through gathering pay stubs and other forms of paper documentation.
Okay, thank you very much.
Yeah, Ms. Representative Cotiza-Witun.
Next question was on doula data, Mr. Reyes. Just curious, based on some of the infant mortality rates that we saw earlier in the presentation, do we have any additional data based on mothers who choose to use the doula services that are available? And do we see any difference in infant mortality, maternal mortality, those types of things?
Ms. Justo or Mr. Reyes.
Thank you, Mr. Chair. We do have some data, I don't have it with me today, that shows the utilization of doula services. We have had some trouble in sort of getting increased utilization in that service because of some of the requirements within the program. Predominantly, maybe some of you guys heard this, is the requirement within our state plan, and the state plan is the kind of, if you will, agreement or contract we have for the Centers with Medicare and Medicaid Services for the state Medicaid program. And one of the requirements in that from CMS is that the doulas be supervised by either a physician, a nurse practitioner, or a third provider that I can't remember right now. And what we've heard from the doulas, it's been difficult to find some folks that are able to supervise them in this space. And so as a result, we know that the utilization for doula services, at least that we get billed for, is less than what might be out there in the community. And so we don't have the utilization is considerably low right now. And so I don't think that we would see any impact on the infant mortality at this point, given that.
Okay, thank you for the clarification.
Representative Morrison.
Thank you, Mr. Chair. Thank you for your presentation. Going back to medical assistance, I note that children are automatically entered for the first year of life. Women are eligible for 2 months postpartum. Maybe this is more of an editorial comment than a question, but that strikes me that given what we know and what we're learning about infant and maternal mortality, that women should probably be also automatically enrolled for the first year of their infant's life.
Mr. Reyes or Ms. Justo?
Thank you, Mr. Chair. Representative, I would say that is certainly a possibility. We would need legislative authority to extend. Continuous eligibility is a concept that does apply in some other states to pregnant women as well as to children. So it is an option that we would need legislative authority to pursue.
Thank you.
Thank you. I believe Representative Pryor had a question.
Thank you, Mr. Chair. And this is an open-ended question, and just I'm trying to understand maybe the impact, the context for this, and what it means to Minnesota. But going back to that statistics that you're giving us, it says 43% of births are covered by Medicaid in Minnesota. Is that, and that's what I'm understanding by that. So how does Minnesota compare to other states? What more can you tell me about that statistic? So I understand better the impact of it and on, the population that we're talking about, the prenatal to early childhood. What does that mean?
Ms. Peterman, Ms. Justo?
Chair Representative, thank you for that question. That statistic comes from when we look at what we know of the total number of births from birth certificate registry data from the Department of Health compared to what we pay for at the Department of Human Services. I don't know how that compares to the proportion that's paid for by other states' Medicaid programs, but at least for me, that is a important recognition that the Medicaid program has a substantial impact on the health and well-being of our kids and their future, and so it's kind of an acknowledgement of that responsibility that we are paying close attention to the care there.
Ms. Peterman and other testifiers, can you just make a connection with the first presentation from Ms. Castellano? Because it occurs to me, we talked about prenatal care disparities and these massive disparities that are actually getting worse, it seems like, for several of our populations. And then nearly half of births are under Medicaid, and I suspect they're even drawn from populations that are disproportionately affected by that. So this program is really very tied into those prenatal care disparities and birth disparities. Can you talk about what you all are doing then in administering this, or what's being done through this program to ameliorate those disparities? For any of the testifiers, Ms. Peterman, perhaps? We can see who wants to take that.
Thank you, Mr. Chair. Certainly, so we have several benefits in the Medicaid program that could potentially help the population that you're speaking of with this issue. And so one, I think, main crux of it is our child and teen checkups program. Our participation rate within the state is around 70%. The teeters between 70 and 73%. There's some nuances in those numbers that I don't know if we have to get into right now, but we are actively working on improving that. One of the things that we're doing is having annual visits for older populations, which I know isn't quite your purview, but improvements in that space and is, I think, a big step, because that's how we identify things early and make sure that kids are getting the services that they need. We also, for example, cover things like nurse home visits. So after a parent has a child in their home, the nurse might come to their home and help do certain things, like help them understand safe sleep habits, for example, that was brought up in the previous presentation. And so we pay for quite a few of those within the program. We've done some enhancements over the years in partnership with the legislature to improve payment rates for those folks so that they can be more accessible to individuals on the program. We also have another program in our, and I don't know too much about it, so I apologize, but focuses on women who are American Indian and African American who might have some addiction in their life, and helping them with when they're pregnant. So that's another grant program that we're working on right now within the department. And so I could probably list about 10 to 15 of those different things, the small pieces. And usually what happens is, depending on the individual, they might access different of these services, right? Not everybody uses a doula, not everybody uses a community health worker, but they kind of can access a myriad of these different services.
I guess I wonder from your answer whether there may be some opportunities, though, for some collaboration between MDH, which is noticing these disparities and trying to address them, but then probably about a majority of the births affected are actually being funded through Medicaid, which you all oversee. So I just wonder if there may be some opportunities there to explore. Any other questions from members? Representative Wozlowick.
Mr. Chair, testifiers, I am just wondering what sort of outreach is done to folks in this program. It seems to me that whenever I need to know what a covered benefit is or what's available, I have to go and find that information. It's not always super clear or easy to find. So I'm wondering if you can talk a little bit about what sort of outreach you're doing to these communities, both when they kind of start on the programs and continuing as well.
Mr. Reyes?
Thank you, Mr. Chair and members. So as Ms. Justo had mentioned, about 75% of our population is served by managed care organizations, and the majority of kids are served by managed care organizations. So a lot of that outreach does happen from the managed care organization. On On the well child visit, or on the child and teen checkups front, that is work that the department does for the entire program, regardless of whether the individual is on fee-for-service, as we mentioned, or managed care. And so it kind of depends on what service you're talking about, but the majority of that outreach would be done by the managed care organization serving that child.
Thank you. And any other member questions? I am not seeing any. We very much appreciate you getting us off to, helping to get a lot of Minnesotans off to a good start, and then getting us off to a good start as well. So thank you very much. Members, to confirm what was said on Tuesday, we will not have a meeting next Tuesday, so extend your 3-day weekend if you wish. We will be meeting next Thursday, and so you can look at that there. I'm trying to set up individual meetings with everybody on the committee and would love to hear about interest both on the GOP side, DFL side, for areas you want to focus on, and would love to have this be a collaborative effort. Thank you very much, and we are adjourned.